Alright, MCQ of the day, episode 6, and with the help of this MCQ, the topic we are going to cover today is UTI in children. Let's dive into the MCQ. So here he has given that the patient is a 2-year-old and a girl. Previously healthy 2-year-old girl is brought to the emergency department by her parents with 4 days of intermittent fever and foul smelling urine and decreased oral intake. She has no vomiting, diarrhea, rash, okay, and she cries during urination. Okay, so he is giving clear clue towards urinary tract infection. No doubt on that. She attends daycare but no sick contacts. Okay, she does not have any sick contacts. There is tachycardia, BP is normal. There is mild suprapubic tenderness but no CVA tenderness. What is CVA? CVA is costovertebral angle tenderness. Capillary refill is moderately dehydrated and the WBC are elevated, CRP is elevated, nitrate is positive, leukocyte esterase is positive, 5 RBC and no cast. ठीक है, इस पे will going to have discussion on this. And 3 plus WBC, specific gravity is normal, culture is pending, urine culture is pending, so we have started intravenous resuscitation. We have started to give him IV fluids and ultrasound is ordered, but it will take 2 hours. So basically the examiner is saying you that you cannot do immediate ultrasound, and what should be the next step. So before we go into all that, let's understand the question and what we can get out of the question. So this is a patient who is 2-year-old brought with fever and she cries during urination. So the examiner is directly saying you that she is having UTI and he is asking the treatment of UTI. That's what the examiner is directly asking you. But over here you see that this is a 2-year-old and she is crying during urination. So the examiner has kept the difficulty level slightly easy. What the examiner can do is that see very young children like 4-month-old, 6 months-old, 10 months-old, less than 1.5 2 years, they can only have fever and no this kind of symptoms like crying with urination or this kind of bladder symptoms. Okay, dysuria and all those symptoms might be absent in younger children who are particularly infants. So if he really wants to go hard and really wants to test you, he will not give this in exam. Then you have to say that it is UTI without this hint. Then how will you say that without the hint? Because if it is a young patient and young patient having fever more than 102, more than 102 Fahrenheit, without diarrhea, without respiratory system, with respiratory symptoms, without symptoms of any other system, without symptoms of any other system. So no GI symptoms, no respiratory symptoms, no neurologic system. Then you should suspect UTI if it is a girl और ए अनसर्कमसाइज्ड मेल चाइल्ड. ठीक है, जनरली इन्फेंट. सो बट इधर एग्जामिनर ने डायरेक्टली दिया है कि शी इज हैविंग यूटीआई and there is suprapubic tenderness, so it means that there is inflammation of the bladder. ठीक है, if there is any suprapubic tenderness, it is indicating that there is inflammation of the bladder, but no costovertebral angle tenderness. Now either examiner क्या बोल रहा है? Here the examiner is saying that there is no pyelonephritis, because if there is a costovertebral angle tenderness, it means that the kidney is involved. Here the examiner is telling you the kidney is not involved but the bladder is involved. So he is pointing you towards the UTI, he is pointing you towards cystitis. If he would have told that there is costovertebral angle tenderness, you should suspect some renal pathology. ठीक है, तो this is how you should approach in the examination. WBC elevated, ठीक है, points towards infection. CRP elevated, points towards cause inflammation in the body. Nitrate positive, this is very important in the urine analysis. If you are getting nitrate positive, it means the causative bacteria, examiner is giving you a hint that the causative bacteria is E. coli. Okay, that the causative bacteria is E. coli, and it is E. coli UTI. Leukocyte esterase positive. See, if in urine analysis you get leukocyte esterase, it means that there is active WBC in the bladder. There is some WBC action going on in the bladder. Okay, and then we have got WBC also. We have got 5 RBC also. So it is hematuria, not hemoglobin urea. If less than 2 RBC, तो अपन hemoglobin urea या myoglobin urea ऐसे suspect करते. But here 5 RBC, so direct he is saying hematuria. No cast, so no renal pathology is there. ठीक है. If for example there were the RBC cast, so your diagnosis should go towards glomerulonephritis, RBC cast. You cannot forget that. Then there is a whole other topic about cast. And he is saying that bladder ultrasound will take some time. And what will you do? So in cases of UTI, we have to start the antibiotic treatment as soon as possible, because if we delay antibiotics, it is going to result in renal inflammation and renal scarring. So there will be long-term and permanent and irreversible kidney damage if we don't act fast and if we don't act accordingly. So first we'll see the options. Start amoxiclav and discharge with follow-up. No, amoxiclav is not enough for empiric treatment of UTI. IV ceftriaxone, admit for observation and await ultrasound results. This seems to be the right answer. Lumbar puncture. No, we do not have any findings of meningitis. Like he would have told some neck findings. If we were suspecting lumbar meningitis, there would have been some findings like neck stiffness or something like that. So वो नहीं है. Clearly it is renal pathology. Voiding cystourethrogram immediately. See, we need to get a voiding cystourethrogram after the patient recovers after 2 weeks. So the general funda is that patients who are less than 2 years old, patients, if they get UTI, you treat them with IV antibiotics. You let them recover. After they recover, you do a renal and bladder ultrasound. If the renal and bladder ultrasound is abnormal, then you do a voiding cystourethrogram. So we want to basically see if there are any other diseases which are causing this repeated UTI, like valvular diseases, this vesicourethral reflex, those kind of structure abnormalities in the urinary tract are there or not. We want to see that. So after we treat the patient, we'll do renal ultrasound. If the renal ultrasound is abnormal, we do a voiding cystourethrogram, but we do not do it immediately. Okay? We do not do it immediately. Maybe later on we'll do it. And IV furosemide to force diuresis and prevent renal scarring. See, renal scarring will be prevented by your antibiotics, which is ceftriaxone. Renal scarring will not be prevented by diuretics, and this furosemide is only going to increase dehydration, so it's going to do only more harm. So the option is IV ceftriaxone. It is a third generation cephalosporin, and third generation cephalosporins are the empiric treatment for UTI, but you need to do culture also before starting the antibiotics. Do culture, wait for the culture results and sensitivity, and you can later on change your therapy, but this is the empiric treatment of UTI. So we have in short discussed childhood UTIs. There's a lot more to this topic, but I have done what I can with the help of one MCQ. So this is the goal of this series, that every day we do one MCQ and we cover one topic with the help of that MCQ. So support me in this journey, like, share, subscribe to this channel. I am going to put up somewhere here the playlist of the MCQ of the day. You can see the other episodes also of the MCQ of the day. Bye bye.